Good evening, everyone. This is Meldita. I'm back here at my YouTube channel, Meldita's Info Corner. And this is my YouTube, johnrigacho@yahoo.ca. We have here an anterolateral STEMI. So we have two STEMIs in here, anterior and lateral, caused by ectasia with clots. Okay, so we have a 70-year-old male in here with a diagnosis of anterolateral STEMI, complaining of severe chest pain. And he complained of severe chest pain at home in the morning, radiating to his jaw, becoming nauseous and vomiting, and called 911. Okay, if you look at the cardiac risk factors here, you don't see anything. No cardiac risk factors, but if you look at the other history, we have Lyme disease, myocarditis, OSA or obstructive sleep apnea, there's no CPAP, a current alcohol user, and has colostomy secondary to Crohn's disease. Okay, so upon arrival at home, because the patient called 911, the advanced life support crew did 12-lead ECG. And the patient has here a junctional rhythm with ST elevations in the lateral leads, 1, AVL, V5, and V6. And there are also ST elevation in the anterior leads, V3 and V4, and a little bit of V2. Okay, so the patient's rate is 45 beats per minute, junctional rhythm, but the blood pressure is very good. We have 130/70, so the patient did not complain anything, no dizziness, and no lightheadedness. If the patient has a low blood pressure, then he will become for sure symptomatic. So luckily, we have a nice blood pressure, although the patient's heart rate, that's still a good combination until the patient is fixed. So with regards to the chest pain, they give nitrous spray sublingual and fentanyl intravenously. And for nausea and vomiting, the advanced life support crew gave gravel intravenously, and they loaded the patient with aspirin orally. Okay, so the patient went to the cath lab, and this is what we have here. So the interventionalist cardiologist saw the following. So we have here an ectasia of the right coronary artery, an ectasia of the left anterior descending artery. So when we say here, why this thing is happening, there's no atherosclerosis in here, but just plain ectasia of the right coronary artery and ectasia of the left anterior descending artery. In here, we have a weakening of the arterial wall, and then there is also a diffuse dilatation of the coronary arteries. Imagine almost the entire length of this right coronary artery and the left anterior descending artery. Okay, and I have a reference in here. So we have here an arterial wall weakening, and there is followed by a diffuse dilatation of the coronary artery here. I have here the reference in here. And this is different from coronary aneurysm, because in coronary aneurysm, you have a focal coronary dilatation. For ectasia, we have a diffuse dilatation of the coronary artery. And this is what we have. An ectasia of the RCA, an ectasia of the LAD, with lots of clots inside. So the interventionalist did suction as much as he could for these clots. So a lot of clots in the coronary arteries, and the interventionalist suction as much as he could. Okay, and not only that, we have an anomalous circ. So the circumflex artery usually joins the LAD connected to the left main. We have no left main, so the circ connects to the right coronary cusp together with the RCA. Okay, and the LAD has its own opening, and it is alone because we have no left main. But one thing, we have no blockages except for the structure that is ectatic, with lots of clots that had been suctioned by the interventionalist. Okay, and this anomalous circ so far shows no blockages, which is good. Okay, so the ejection fraction is 30 to 35%, and the end diastolic pressure is 12, which is acceptable even until 14th. Okay, so here the radial band is applied, and that will be taken off in CCU after such time. Okay, using the tear band or radial band to the right radial artery, because that is the port of entry going to the coronary arteries. Okay, so here the angiogram was successful, thrombosuction was successful. Okay, and the interventionalist ordered an anticoagulation in CCU. Okay, using an unfractionated heparin infusion, and that will be started 2 to 4 hours after the radial band comes off, or they determine the time when to come off. Okay, the doctor also ordered Definity echo, okay, to rule out any clots in the left ventricle, and of course it will show you a left ventricle ejection fraction or LV function. And then the plan last will be to repeat angiogram after a thorough anticoagulation is finished in CCU. And then with that repeat angiogram, the interventionist will determine the best plan for the patient. Okay, So let's see if the patient's procedure succeeded by looking at the following ECGs in CCU. Okay, after 1 hour, 1 hour and a half, repeat ECG 12 leads are done in CCU. And you notice that the ST elevation in the lateral leads, 1 in AVL, B5 and V6, went now to, they came down and now at the isoelectric line, which is good. So ST elevations in leads 1, AVL, B5 and V6 representing our lateral leads are now isoelectric. And so with our anterior leads, B3 and B4 and a little bit of B2, they went also isoelectric. So the duration of the evolution here will be shorter, and it looks like the management was done quicker. Okay, so with the same, or the 12 lead ECG is the same isoelectric line for the STs. And then after about 9 hours, we see that the T waves are starting to appear in the lateral leads, 1, AVL, and 5. And we also see an T wave inverting in anterior leads, B3 and B4, and that of B2. Okay. And then in the morning, more progressive and deeper T wave inversion is seen here in the lateral leads, 1 in AVL, and then B5 and V6, and also B2, 3, B4. Okay, so the duration of our evolution is shorter, and the management for revascularization happens quicker because all the clots, most of the clots are done. Okay, and as I said, the succeeding angiogram will show more, result of what has been done to this patient. Okay. So if you look at the history here, there's a mention of Lyme disease and myocarditis. Okay. Basing from the proposed etiologies, there are proposed etiologies for this coronary ectasia. There are proposed etiologies, and it has been mentioned. So this reference mentioned that one of these etiologies, or one of these proposed etiologies, is bacterial infection secondary to Lyme disease. Okay, so exactly what is Lyme disease here? So in here, Lyme disease is a bacterial infection, and the cause is the Borrelia burgdorferi. This is a bacteria. Again, I get the reference there. And this is transmitted. So this bacteria is carried by this deer tick. The other name for the deer tick is the black-leg ticks. They carry this bacteria, and as they bite human beings, they will transmit this bacteria to the human beings or to the victims. Okay, so it is through their infected bites, okay, that will transfer the bacteria to the humans. Okay, the bite of this tick, deer tick, is usually causes a rash, okay, and it's like a bull's-eye rash. For some, maybe it's nothing. It will not show, they will not contract any symptoms or anything. They will be okay. For some, they might just probably nothing, okay, it's just a rash. But for others who are vulnerable or susceptible, they can actually develop symptoms days to weeks after the bite. And they think like they have a flu-like symptoms. They have a low-grade fever and chills. They have headache, muscle and joint aches and pains, stiff neck, poor appetite, swollen glands, and fatigue. Okay, so they think that they might just having a flu-like symptom. If others do not ignore this and they think that there's something going on, they usually submit themselves maybe to a clinic, to ER, and they will find out, they will dig the history, and they will come up with a treatment, and